Welcome back to the deep dive. We've covered a lot of ground, chapters 1 through 5, and now we're ready to tackle chapter 6 of Stahl's Essential Psychopharmacology. Big topic today, mood disorders.
That's right. And this chapter really gets into the nitty-gritty, the neuroscientific underpinnings. We're aiming to, really unpack it for you, especially if you're maybe an incoming resident or just starting your PGY 1 year.
Perfect. So the goal is extracting those key insights, giving you that solid foundation.
Exactly. It's complex stuff, but understanding the why behind the symptoms and treatments is, well, essential.
Okay, let's dive in. Chapter 6 starts by framing mood disorders as existing on a spectrum. It's not just, feeling down or feeling up.
Precisely. Think of it as a continuum. At one end, you have major depression, at the other, mania. But crucially, there are states in between these mixed states where depressive and manic symptoms can actually occur together.
Mixed states.
Okay.
And the chapter really emphasizes distinguishing unipolar from bipolar depression early on. Why is that so critical?
Well, it fundamentally changes everything, the prognosis, the treatment approach. Getting that distinction right is probably one of the most important things for effective care. You treat them very differently.
Right. And you mentioned mixed features, so we need to be watching for those subtle signs too, like subsyndromal mania even within depression.
Absolutely. Detecting those mixed features, even if they don't meet full criteria for mania or hypomania, is key. It has big implications.
Okay. And it's not just about the mood itself, is it? The chapter says you need more than just feeling sad or euphoric to diagnose a major depressive or manic episode.
That's a vital point. Yes, the mood change is central, persistent low mood, or that elevated, expansive, even irritable mood. But you need a cluster of other symptoms too.
Like what kind of symptoms are we talking about?
Well, for depression, think changes in sleep, appetite, energy levels, concentration, feelings of worthlessness, psychomotor changes, either slowed down or agitated, and unfortunately, thoughts about death or suicide. And for mania, it's things like inflated self-esteem, grandiosity, much less need for sleep, racing thoughts, being way more talkative, distractibility, getting really goal-directed, sometimes to an excessive point, or engaging in risky behaviors. It's the pattern, the duration, the impairment.
Got it. So, moving on to the causes, what's the thinking now? I remember the old kind of simple idea about low serotonin causing depression.
Yeah, the classic monoamine hypothesis. Deficiencies in serotonin, norepinephrine, dopamine. That was foundational, but we've moved quite a bit beyond that.
So it's more complicated.
Oh, definitely. Monoamines are still involved, for sure. The current view incorporates so much more. We're talking neurotrophic factors like BDNF, brain-derived nurture factor disruptions in sleep and circadian rhythms, neuroinflammation, the whole stress response system, the HPA axis.
Wow.
And of course, genes and environment interacting. It's a much richer, more complex picture. Thinking about things like neurotrophic factors and inflammation actually opens up new treatment possibilities beyond just boosting neurotransmitters.
That's fascinating. Listening to this reminds me of, well, never mind. The chapter also raises a pretty concerning point, this idea that mood disorders might actually progress if they aren't treated effectively.
Yes, that's a really important and frankly sobering concept backed by longitudinal data. There's evidence suggesting that some cases starting as unipolar depression can evolve.
Evolve how?
They might develop those mixed features we talked about, then maybe progress towards full bipolar disorder and potentially become more treatment resistant over time. Even just having subthreshold manic symptoms seems to increase that risk significantly.
Subthreshold. So even if it doesn't quite meet the bar for hypomania.
Exactly. Each additional symptom seems to add to the risk. It really highlights why getting effective treatment early is so critical.
Okay, so given all this complexity, the spectrum, the various symptoms, the potential for progression, how do clinicians approach treatment? The chapter mentions a symptom-based approach.
Right. The core idea is trying to link a patient's specific symptoms to potential dysfunctions in specific brain circuits. Different circuits, regulated by different neurotransmitters, handle different functions: mood, sleep, energy, concentration, anxiety.
So you map the symptoms onto the brain, essentially.
Kind of. You identify the symptom cluster and hypothesize which circuits might be misfiring or inefficiently processing information. Then you choose treatments targeting the neurotransmitters active in those specific circuits.
To try and fine-tune the processing in that circuit and alleviate the symptom.
Precisely. And this applies whether you're dealing with depressive symptoms or manic symptoms.
Interesting. So it's about understanding which neurotransmitters regulate which circuits to tailor the treatment.
Exactly. For example, if anxiety and insomnia are big problems alongside depression, you might think about treatments that boost GABA, the main inhibitory neurotransmitter.
Okay. And the chapter talks about key players like GABA, serotonin, histamine.
Right. Boosting GABA, maybe blocking certain serotonin receptors or histamine receptors, can help with symptoms like anxiety, agitation, insomnia.
And for other symptoms.
Well, if fatigue and poor concentration are major issues, maybe boosting norepinephrine or dopamine pathways might be the strategy. Sometimes there's interplay. Serotonin, GABA, and histamine might all be involved in a particular presentation.
Concentration issues. Yeah. My ex-wife used to say, well, she definitely struggled with focus sometimes. Seemed like she could have used a dopamine boost, maybe. This circuit idea also ties into circadian rhythms, doesn't it? How does our body clock fit in?
Yes, a very strong connection. Circadian rhythm disruptions are super common in depression. You see changes in melatonin secretion, cortisol levels. It affects sleep, energy, mood.
And light is the big synchronizer.
It's the most powerful one, yeah. Light hits the retina, signals through the retinohypothalamic tract to the SCN, the suprachiasmatic nucleus in the hypothalamus. That's our master clock.
SCM.
And the SCN tells the pineal gland when to make melatonin. So things like bright light therapy, especially in the morning, can actually help reset those rhythms in people with depression.
So it's not just pharmacology, it's also about environmental factors like light. Interesting. Now, how do these neurotransmitters actually regulate information processing? The chapter mentions improving processing in circuits related to fear, anxiety.
Yeah, the thinking is that neurotransmitters like serotonin and norepinephrine modulate how efficiently signals are processed in circuits dealing with negative emotions, fear, anxiety, irritability, hostility, loneliness.
So if someone has symptoms across multiple domains,
they might need treatments that boost all three main monoamines, serotonin, norepinephrine, and dopamine, but it gets even more complex. Some newer thinking suggests the problem isn't just too little or too much neurotransmitter.
What then?
It might be more about inefficient or even chaotic signaling within the circuits, like the information isn't getting through clearly, it's distorted.
Like static on the line.
Exactly, not just low volume, but a bad connection.
Which brings us back again to how vital that initial diagnosis is. Getting it right, unipolar versus bipolar.
Yeah.
Identifying mixed states.
Absolutely paramount. You can't choose the right tools if you don't know what you're fixing. And remembering it takes that cluster of symptoms, not just the mood change.
And this symptom-based thinking, it works for associated symptoms too, like anxiety or pain that often come along for the ride with depression.
Yes, that's a huge advantage. You can target anxiety symptoms using, say, serotonin or GABAergic agents, even if the person doesn't meet full criteria for a separate anxiety disorder.
Because the mechanism works on that anxiety circuit regardless of the main diagnosis.
Precisely. Or using SNRIs, serotonin norepinephrine reuptake inhibitors, for painful physical symptoms that often accompany depression. They target norepinephrine pathways involved in pain modulation.
Anxiety. Oh, she definitely had that. Quite a bit, actually. But, okay, even with these targeted approaches, treatment isn't always straightforward. The chapter notes remission rates aren't great, especially initially.
No, unfortunately. For unipolar depression, maybe only about a third of patients remit fully with the first antidepressant they try. And the odds seem to decrease with each subsequent single medication trial.
That's tough.
Yeah.
Really underscores the need for persistence
Yeah.
and maybe combination strategies.
It often does. Careful assessment, adjusting treatment, sometimes needing multiple agents working on different targets.
Now back to that tricky unipolar versus bipolar distinction. If someone presents only depressed, no clear history of mania, are there clues? Things that make you suspect it might actually be bipolar depression?
Yes, there are some clinical flags. Things like a very early age of onset for the first depression, a strong family history of bipolar disorder, maybe psychotic features during depression, or atypical symptoms like sleeping more and eating more.
Instead of the typical insomnia and weight loss.
Right. Also, things like postpartum depression history, or, very importantly, if they've had a bad reaction to antidepressants alone, like getting agitated or even switching into hypomania.
So the response to treatment itself can be a clue.
It absolutely can. And this is where getting collateral information is so vital. Talking to family, someone close. They might have noticed periods of elevated mood or behavior changes the patient doesn't report or recognize. Asking, "Where's your mama?" or partner, metaphorically speaking.
Makes sense, even the whole story. Let's zoom in on GABA for a moment. We mentioned it for anxiety, but how does it work exactly?
Okay, so GABA is the main inhibitory neurotransmitter. It binds to GABA receptors, which are these complex protein channels on neurons. When GABA binds, it opens a chloride channel.
Chloride ions flow in.
Negative ions flow in, making the neuron less likely to fire. It calms things down. Now, benzodiazepines, they don't open the channel themselves. They bind to a different spot on the receptor.
But allosteric site.
Exactly, a modulatory site. They're positive allosteric modulators, or PAMs. They make it easier for GABA to open the channel, increasing the frequency of channel opening when GABA is present.
So they enhance GABA's natural effect. GABA has to be there for them to work.
Crucial point. They amplify the inhibition. They don't create it from scratch.
Got it. And lastly, this monoamine receptor hypothesis. It tries to explain why antidepressants take weeks to work, even though they boost neurotransmitters right away.
Correct. The idea is that maybe in depression, the postsynaptic receptors for monoamines become upregulated, more sensitive, more numerous, perhaps trying to compensate for low neurotransmitter levels.
Okay.
So when an antidepressant quickly increases the monoamines in the synapse, that sustained increase gradually causes those receptors to downregulate, to become less sensitive over weeks.
And that downregulation is what correlates with the therapeutic effect.
That's the hypothesis. The timing fits better with both the delayed clinical improvement and also why some side effects tend to fade over time the receptors adapt.
Okay, wow. We've covered a huge amount from just Chapter 6, the whole spectrum of mood disorders, the shift from simple monoamines to this complex interplay of neurotrophics, inflammation circuits, circadian rhythms.
It really is intricate. And understanding that symptom-based approach, linking symptoms to circuits and neurotransmitters like GABA, serotonin, norepinephrine, dopamine, it provides a rational way to think about treatment.
It emphasizes the interconnectedness of it all. Mood, brain wiring, chemistry.
Absolutely. And the critical need for accurate diagnosis, unipolar, bipolar, mixed states, to guide those treatment decisions effectively.
So thinking about that potential for progression we discussed, if untreated mood disorders can worsen or evolve over time, what's the big takeaway for clinicians and really for anyone affected? What should we be thinking about long term?
That's the crucial provocative thought, isn't it? It really drives home the imperative for early detection, comprehensive assessment, and aiming for full sustained remission. Not just patching symptoms, but potentially altering the long-term course of the illness through timely and effective intervention.
Powerful stuff. This has been incredibly informative.
Well, that was certainly insightful. You know, listening to you talk about all those symptoms and your ex-wife. That's funny because I'm your ex-wife.